There's the kiwi.
It's just kind of fuzzy too.
It is fuzzy, isn't it?
I want you to use your strong hand to hold the jars.
Okay.
So ladies, we're going to be making spaghetti.
Oh, good.
And I think it's really important when you're making any sort of meal that you add as many vegetables as you can. My name is Joanna Beal, and I work as an occupational therapy assistant in mental health. I have education in addictions as well. I've taken a psychosocial rehab course, which is based solely on mental health. When I'm assigned a client, it's through the occupational therapist, so I don't pick up clients on my own. I work with two different types of clients, depending on which service I'm working for. So I work in a community schizophrenia service clinic, in which case those clients all have some sort of psychotic disorder, and they have been referred to our clinic to be stabilized. When I work on inpatient, it's a mood disorder service. So it's anyone that has suffered from mania, depression, anxiety. We work as a multidisciplinary team. So I actually run groups with social workers. I have run groups with the recreation staff. We collaborate a lot with nursing staff so that everybody is using the same approach with the client.
Hi Molly, are you ready for therapy?
Yeah.
All right, let's go.
Okay.
My name is Jacqueline Penner. I'm an occupational therapist assistant. I became an occupational therapist assistant by going to a local college. Within stroke rehab, I'm assigned various tasks, and they could be anything from activities of daily living, in other words, washing and dressing and grooming practice, to doing things of IADLs, so cooking, money management, medication management, to things of basic function, hand strengthening, range of motion, hand activities. We try to keep our focus on the functional as much as we can, so even though they need to practice their grip or they need to strengthen their fine motor attributes, we try to do it in a way that might be more meaningful for them within rehab. You're going to try to bend your fingers and really pinch it. Okay? Good, yeah. Really use that thumb. My role on the healthcare team as a support worker is that I'm basically key in communicating, or as I like to say, I'm the meat in the sandwich. So the therapist will come and be the bread. They'll assess the patient, devise their treatment plan, and then they will provide me with the assignment that I have to fulfill and follow through on with the patient. So then I will come and do the treatment, and the therapist will occasionally reassess and then discharge, therefore closing the breaded sandwich. Throughout, my role basically is to communicate with the therapist if there's any changes with the patient, and to communicate with the team, nursing staff, doctors, as needed if there's any kind of medical change as well. The other things in my role that I do that may not be related directly to patient care are educating staff, patients and family, keeping inventory, generally assisting the therapist and my team as much as I can, be it from something as simple and mundane to, photocopying, to something as complicated as teaching patients' families how to best help their loved one at home.
My name is Linda Davies. I'm an occupational therapist assistant. I'm one of the few that's also in the private sector rather than the public sector, which would be the hospital or clinic setting. Very different with regards to not only my traveling to people's homes to treat them, but also as far as I am an independent contractor. I have a business license. Hi, how are you?
Good, thanks. You?
Good.
Good.
Because I deal with motor vehicle accidents, a lot of them have had quite a traumatic event in their life that they did not expect. Some of them have post-traumatic stress disorder, emotional difficulties, mental health difficulties, and some of them do have brain injuries that we treat as well. This is what we've come up with. These are ski socks. And what we've done is we've cut off a spot in the end here so that you can put your whole hand through, or if you want to cover your fingers and just have your thumb through like this. The whole idea of it is for you to be able to go outside and not have that irritation and pain that you get from the hypersensitivity and the cold. The OT will assess them for devices, will make a recommendation in the report. I deliver and review them with people, provide education. Scooters are one of the devices that we provide. They help with community integration. Somebody that can no longer visit the neighbor down the road, get to the local store. So we will take the scooter out, we'll have some lessons. Everybody's sidewalks are different. Some of them are in good repair, some of them are not. And then local stores as well, the threshold stairs to get in, and even negotiating the aisles around the stores.
On the inpatient unit, I see them on the unit usually. I will take people off the unit depending on what we're doing. Outpatient is different. I've seen people in their homes, I've met people at rec centers, I've met them at the grocery store, we'll meet at Tim Hortons. It all depends on what's going on with that person and what the OT has asked me to do with them. You ring the bell there, okay, and you get off at the next stop. Okay? On the inpatient unit, the typical stay is about a month, sometimes a little bit more. I may not have that person on my caseload the whole time. Or I may see them once they've been discharged just for a couple of visits to make sure everything's okay. Up there, it depends on the inpatient unit on what's going on with the person, how well they're stabilizing. And then the OT typically follows them on outpatient after they've been discharged.
So I do see clients in the home, and it's usually after discharge from the hospital. It can be years that I'm actually seeing them until they settle. I do have to communicate regularly with the OT to make sure that I'm staying on track with their recommendations from their reports. So we do call, fax, email, and there are regular team meetings.
We meet in both services every morning to make sure that we're both on the same page with people. Hey there, how are you?
Good.
Good.
Good. How did your group go?
It was good. Yeah. It was really good. Yeah, we had a lot of good feedback about the recipe.
So was there any tension in the group?
She needed to be reminded to take the pot off of the stove to stop it from cooking, and she didn't turn the stove off.
Okay, I'll be able to do an assessment and kind of watch for those things. So I appreciate you letting me know that. So I think it would be good if next time we focus in on these individuals.
Okay, great. Fantastic. So I will see you over at the unit.
Okay, I'll see you then. Thanks, Jill.
Every week they have what's called as rounds, where the therapists, the doctors, the nurses, and the whole team meet. And so the therapist and I will touch base before she attends the rounds so I can provide her with any needed update. And then after the rounds, she'll provide me with the update that the team has provided regarding that patient.
I've been working mostly on catastrophic files, which there's extensive injuries. So you get a large team working on those files. You can have an occupational therapist, physiotherapist, speech language pathologist, assistants, psychologists, case managers, and usually a lawyer or even sometimes the adjuster will attend those meetings. Quite often on the team, I'm one of the ones that sees the client the most. I may see them once a week, twice a week, whereas the occupational therapist may see them once a month or even longer.
I always have to chart the same day just because of the fact that I'm not in the same service the next day usually. I chart with every intervention and with every group. So there is processes that they use depending on the service to make it easier if you have a larger group. We have some progress note stickers that we can use with some check boxes as well as a spot for documentation. I chart what I see and what the person has done and if something unusual has happened with them. As far as treatment approaches go, we use a psychosocial approach, so it's very client-centered. We have a wellness recovery action plan that we try and do with people that kind of gives them a large say in what their treatment is.
To maintain client-centered practice translates to respecting my client's needs, be it through their direct communication or indirect. I'm trying to observe my client that I'm working with and see what they're trying to communicate to me and respect that. If it's that they need to be working in a quiet space, if they need to call the session short today, if they're seeming emotional or fatigued. Good.
In our service, we always make sure the occupational therapist obtains the informed consent first before I even get involved. So when I'm assigned somebody, the first thing I do is let them know what we're going to be doing and ask if it's okay.
With a therapist's initial meeting and assessment of the patient here, they will obtain consent through the patient and or the family that's representing the patient, depending upon the situation. I will then go in with that general assumption that I have been permitted to treat this patient. What I will do when I encounter a patient who has declined therapy is I will remind them that they're in rehab to get better, and that's what I'm hopefully here to help them with, and to show them kind of the risks and the benefits. You know, the risks if we don't do this today, here's the benefits if we do, and if they still decline, and that's fine, and then I just document and let the therapist know.
I think the biggest challenge that I see in my practice is financial. With us being a hospital, there's financial constraints as far as budget and being able to get the supplies we need sometimes. The other thing is stigma. People are self-stigmatizing as well. So having to combat that with the person and then the society in general is so frustrating.
Every home is different, every situation is different, and you have to deal specifically with that person.
Sometimes the things that are said or done may seem uncomfortable or potentially hurtful, and I think it's important to remember that they're going through a transitional time, a difficult time, and it's never a personal thing, it's just their life has had a profound change and we need to respect that, and so that's what I tried to do, and just be friendly. That's very close. How much do we have here? Take your time.
I think I most enjoy seeing people progress, seeing that they're starting to meet their goals, that they're starting to feel like they're a productive member of society, that they feel like they're getting better. And I think that's the thing that I really, really enjoy most. That and feeling like I'm helping them in that journey a little bit.
You tell them where you want to go from and to, and they will tell you everything.
Yes, that's good. Well done. Very good.
There we go.